Board. So good morning and thank you all for joining us today for our Colorectal Cancer Symposium. My name is Dina Nelson and I'm the event manager for White Plains Hospital. The funding for this event was made possible in part by the state of New York. The views expressed in written materials or publications and by speakers and moderators do not necessarily reflect the official policies of the state. Just to go over housekeeping rules today, as I said, we are going to record today's event. All of your lines have been muted to limit distractions, but there will be an opportunity to ask questions via the chat throughout today's event. It is now my pleasure to introduce our moderator and one of our speakers, Dr. Joshua Raff. Dr. Raff is a medical oncologist as well as a director of digestive cancer program here at White Plains Hospital, where he has been on staff for over 18 years. Dr. Raff, it is my pleasure.
Thanks, Deanna. Thanks to you and the whole team at White Plains for setting this up, and to all of our speakers and all of you out there listening to this program. This is going to be a great program, short and sweet, over about an hour, with wonderful speakers here from White Plains Hospital. Sophia Nygar, Dr. Nygar from gastroenterology, Nicole Boxer, our certified genetic counselor, Cheryl Leslie, a wonderful dietitian, and I'll be finishing up at the end within the hour. To wrap things up, we will do formal Q&A after the second speaker and after the fourth speaker, but please feel free to write the comments during the talks. So let's get started. Thanks again with Dr. Nygar on colorectal cancer screening.
Good morning, everybody. I'm Sophia Nygar, gastroenterologist at White Plains Hospital. We'll spend the next few minutes talking about colon cancer screening. Next slide, please. So colon cancer is the third most common cancer, both in men and women. Just last year, we lost about 53,000 people for colon cancer, which is a very high number considering colon cancer is preventable. Next slide. Next slide. So the good news is we are seeing a gradual trend, which is going down in death rates in both men and women. Next slide, please. One before that? Okay, thank you. So it all starts as a small polyp, which is a growth of abnormal cells. And this polyp gradually grows, develops some changes, what we call as dysplasia, and eventually becomes cancer. So roughly it takes about 10 years for these changes to take place. But there are some more aggressive cancers which can develop much faster. So we do have time to detect this precancerous polyps and to take them out. And that's exactly what we do when we do the colon cancer screening. Next slide, please. So the question is, when do we start screening? So as you know, we used to start screening at 50 years of age, but recently we reduced the age to 45 because we have been seeing an increasing trend of colon cancer in younger individuals. So now the recommended age to start screening in an average risk individual is 45 years. When we say an average risk individual, it is a person who does not have a family history of colon cancer, has no symptoms and no history of polyps. Next slide. So how common are these precancerous polyps, what we call as the adenomatous polyps or the sessile serrated polyps? It's roughly about 30% in men and about 20% in women. But different studies have shown higher rates depending upon it because it depends upon their ethnicity, age, and other risk factors. Next slide, please. So what are the options for colon cancer screening? The stool test. I'm sure most of you have heard about this. These are popular among patients because they are non-invasive. That means they do not require any, there's no complications from these. So the two of the most common screening tests that we use is the FIT test, what is the fecal immunochemical test, and the multi-targeted stool DNA test, what also called the Cologuard test. So a good screening test should have high sensitivity and specificity. And what does that mean? A sensitivity is the ability of a test to detect people with colon cancer, and sensitivity is its ability to accurately detect people who do not have colon cancer. So if you look at the FIT test, so it can identify up to 79% of people with colon cancer, and it can accurately identify 94% of people who do not have colon cancer. That means about 6% of people will have a positive test, but do not have colon cancer. The Cologuard is slightly more sensitive. It detects about 92% of colon cancer, but there are a lot more false positive tests in this one. The FIT test needs to be done annually, and the Cologuard is repeated every 3 years. Next slide. The biggest problem with these stool tests are, unfortunately, they do not detect the precancerous polyps, especially the flat polyps, what we call as the sessile serrated polyps. And if you think ideally, a screening test should be such that we detect these precancerous conditions and not the cancer itself. And a slide before. And a positive stool test should be followed by a colonoscopy. Next slide. So that's why colonoscopy is the gold standard. It's not only diagnostic, that is, it detects polyps, but it's also therapeutic. That means when we find polyps, we can actually take these polyps out. And there's 100% cancer detection. Next slide. So this is one of the polyps and how it looks after it's been taken out. Next. So below you see a flat polyp. And once it's taken out, that's how it looks on the second slide. And since it's a larger polyp, we put little clips to close it. And the black mark that you see is actually a tattoo, which we place inside so we can identify the site when we go in next time. Next slide. So the most common concerns or barriers for colonoscopy, I feel, are people are worried that it's an invasive test and they're worried about the complications. And the most feared one is the perforation. But a screening test, the perforation rate is very low. It's about 0.01 to 0.1%. And it's also more common if there's a large polyp taken out, or in more complex cases, like if you have to dilate a narrowing or a stricture, or we have to do an emergency case where we have to go unprepped. So really the complications of colonoscopy are very low. And the other one is the bowel prep. Do I have to drink that nasty liquid? Well, we have tablets for that now. You don't have to drink the liquid. So please ask your gastroenterologist if that's something right for you. And the other commonly asked question is about the anesthesia and anesthesia risk. This procedure is done under what we call as the monitored anesthesia care. So it's not really a general anesthesia. We just keep you on a light plane of anesthesia where you maintain your breathing, but you're comfortable and asleep and you don't feel any pain or discomfort during the procedure. And the anesthesia risk in a healthy individual is very low. Next slide, please. Back. Okay. So, and the last screening option that we'll talk about is the CT colonography. This is basically a CAT scan. And this also has a high detection rate of colon cancer, about 90 to 100%. But this is not a good test for flat lesions and also flat polyps. This is, of course, less invasive than colonoscopy, but you have to go through the same prep that you go for colonoscopy. And also there is a risk of radiation exposure with this. And the positive test should be followed by a colonoscopy. That means you'll get another bowel prep for this. And it should be repeated every 5 years. Next slide, please. So another common question I get asked is, when I'm 75, do I still have to screen for colonoscopy? Do I have to continue screening? So screening should be definitely continued until 75 years of age, and between 75 to 80 years, a number of factors needs to be taken into consideration to continue screening. That's the overall life expectancy and the medical conditions, and also what the findings on the prior colonoscopies. If a person had adenomatous polyps, I think it's wise, if they're healthy, to continue screening colonoscopy between 75 and 85 years of age. Next slide. Next slide. Thank you so much.
Thank you, Dr. Nagar. That's great, and I know there'll be questions. I have a few questions that we'll put to you after Nicole speaks about genetic testing. Nicole?
Good morning, everyone. So I'm going to be spending a few minutes with you this morning going over genetics as it pertains to colorectal cancer. So when we consider all cases of colorectal cancer, about 60% of the time these cancers occur sporadically. They occur out of the blue for the first time in that individual and a family. And for these cases, we don't always know the reason why they occur. About 30% of the time, colorectal cancer is familial, which means we may see it more than once in a family, not necessarily due to shared genetic factors, but possibly other factors that two family members might have in common, like diet and lifestyle. And then we have about 10% of colorectal cancers that are hereditary, which means that there is a single gene mutation or a mistake in a gene that causes an elevated risk for possibly not only colorectal, but potentially other types of cancers as well. And that's what I'll be focusing on today. Next slide, please. So what makes us concerned that colorectal cancer may be hereditary in a family? First of all, when we see it at young ages, individuals diagnosed under age 50. When we see multiple primary cancers in an individual, so someone that's developed two different types of cancers. When we see many relatives, particularly on the same side of the family, with either the same or related cancers. So it's not always only colon cancer in a family, but we might see maybe colon or other types of cancers as well that can be genetically related, like uterine or other types of GI cancers. When we see a pattern of inheritance in a family, cancers in multiple generations, what we consider autosomal dominant. And when we think about the development of polyps, we get concerned that that may be hereditary when we see an individual that has a history of multiple polyps, usually 20 or more, cumulatively throughout their lifetime. So it's not necessarily 20 polyps that are detected on one colonoscopy, but when we add up the total number of polyps that someone has had, when we start to see many polyps in an individual, that's concerning that there might be some underlying genetic cause for these polyps and therefore a genetic risk for colon cancer in the family. When we see patients for genetic testing, we draw out something called a pedigree. And a pedigree is a way to map out the family history. And women are symbolized by circles and men by squares. So this is an example of a patient that came in for genetic testing based on her family history of cancer. She's 69 now, but she was diagnosed with colon cancer at age 48. She has two children, a daughter 42, a son 37, A and W stands for alive and well, and two sisters, both in their 60s, who are healthy as well. Their mother had pancreatic cancer at a young age at age 62. Maternal grandmother had colon cancer at 48. Maternal uncle had gastric cancer at 62. And a maternal first cousin had colon cancer at age 39. So when we look at this family history and thinking about some of the red flags that I had just mentioned, we're seeing a lot of red flags, right? So we're seeing young colon cancer in the family. We're seeing multiple relatives in consecutive generations with cancer, and we're seeing related cancers in these families. So not only colon cancer, but other types of GI cancers as well. So this patient underwent genetic testing based on the concern of her family history, and it turns out that she has a mutation in a gene called MLH1. Now, MLH1, next slide, please, is one of several genes that causes a condition known as Lynch syndrome. Lynch syndrome is the most common hereditary cause of colorectal cancer. It's actually quite common in the genetics world. So in the genetics world, when we think about a lot of rare diseases, Lynch syndrome is seen in about 1 out of 279 individuals. So that's actually quite frequent, and it is certainly underdiagnosed. In individuals with Lynch syndrome, we tend to see an elevated risk for particular types of cancers. Certainly, we see a high risk for colon cancer, uterine cancer, other types of cancers as well, like ovarian cancer, cancers of the urinary tract, the biliary tract, and other types of GI cancers. So in individuals with Lynch syndrome, they're not only at risk for colorectal cancer, but other types of cancers as well. Lynch syndrome is inherited in an autosomal dominant manner, which means that if a parent carried the mutation, each of their children, male or female, would have a 50% chance to have that mutation as well. Next slide, please. So the purpose of the genetic test is information, right? So if we know that someone has a mutation, the question becomes, what should we be doing differently to hopefully keep them healthy? How can we use this information hopefully to prevent any cancer, or in this patient's case, any additional cancers from developing in the future? So for men or women that have Lynch syndrome, we tend to recommend starting colonoscopies at a much younger age. So Dr. Nygaard had discussed how the recommended age right now is age 45 for average risk individuals. But for someone with Lynch syndrome, we consider them to be high risk. Therefore, we start our screening much younger, and we start colonoscopies in the 20s. We usually also will do them more frequently in order to get ahead of that polyp growth, which can be somewhat accelerated in Lynch syndrome. So we do colonoscopies every 1 to 2 years, as well as other types of surveillance. So we do upper endoscopies, EGD, annual urine testing. In some situations, especially when there's a family history of pancreatic cancer, we consider surveillance for pancreatic cancer. And for women, because there's a risk for gynecologic cancers, we do consider, once they've completed their family, a surgery to remove the ovaries, tubes, and uterus in order to reduce the risk of that type of cancer. So again, the goal with the genetic test is to identify individuals who have an elevated risk for cancer, so we can hopefully use that information in order to screen more effectively and potentially reduce the risk for cancer in the future. Next slide, please. So going back to this patient, now that we know that she has a mutation, the question becomes, do any of her other family members have that as well? So we offer something called cascade testing to family members. So her son and daughter were both tested, and her son tested positive, and her daughter tested negative, and her 2 sisters tested negative as well. So now that we know that the patient, and in this family, her son, have this mutation, again, the question becomes, what should we be doing differently in terms of increased surveillance or potentially preventative surgeries in order to reduce future cancer risks? Genetic testing is looking not only at single genes or single syndromes, but our genetic testing nowadays is called multi-gene panels. So we're looking not only at the genes for Lynch syndrome, which again is the most common hereditary cause of colorectal cancer, but we're looking at a whole panel of genes, looking at risks for not only colorectal, but other types of cancers as well. And this gene panel is actually somewhat small. It's only 17 genes. Nowadays, our panels are 30, 40, 50, even 80 genes. Again, we're looking at many different genes that can increase the risk, not only for colorectal, but other types of cancers. So again, just to reiterate the main reasons why an individual may undergo genetic testing. If they've had cancer themselves, possibly it helps us understand a reason as to why they developed a particular type of cancer. To better understand or predict their risk to develop a new primary cancer in the future, and therefore we can hopefully implement appropriate methods of cancer screening as well as risk reduction measures. And for individuals that have a family, often they'll want to know if their children or grandchildren may be at greater risk to develop cancer as well. One question that we get asked quite often is about, who in the family should undergo genetic testing. So who is the best person in the family to test? And in order to answer that question, I bring up a relatively simple analogy. So if we have a red apple tree on the left that's growing red apples, and all of a sudden one day we wake up and we look at that tree and one of the red apples has turned yellow. If we want to understand why that happened, why that red apple turned yellow, certainly it would make sense to test that yellow apple itself instead of testing anything else on the tree. So similarly, when we're thinking about a family history of cancer, if we're looking to find out if cancer is hereditary in a family, ideally, we want to start by testing the person in the family who has had cancer prior to testing the unaffected relatives. Now, we understand that that's not always possible. In some families, the affected family members have passed away, or for whatever reason, they're unwilling or unable to undergo genetic testing. So we understand that that's not always possible. But in an ideal world, if we had our choice, we'd always want to test the affected family member first, as that provides the most information for the rest of the family. So I just wanted to close out by going through some common myths and facts as they pertain to genetic testing. We often hear about genetic testing in the news, in the media, and there are often a lot of misconceptions that circulate. So I was hoping to kind of tackle a few of those and hopefully clarify them for you all. The first is about the concept of cost as it pertains to genetic testing. So genetic testing, we hear from patients, well, it costs thousands of dollars. How can I afford it? And the reality is that the self-pay cost for genetic testing through very good qualified labs is $250. Through insurance, most of our patients pay much less, often pay, $100 or even less. I'd say most of my patients pay $0. But most of the time, genetic testing, if you could just back up a little bit, is not nearly as costly as it once was. So it used to cost thousands of dollars, but nowadays it costs much less. On a similar note, oftentimes patients feel that their insurance won't cover the testing, so they won't even make the call to schedule the appointment. And the reality is that if you meet medical criteria, meaning if your family history has at least one or more of these red flags that we had talked about, your insurance will likely cover the cost of the testing. So most patients that come into my office, I would say, have a $0 out-of-pocket cost for testing because many of them are coming in because of a strong, personal or family history. Genetic testing can be done through blood or saliva. So sometimes I'll hear patients say, well, my cousin had it through blood. Why am I getting it through saliva, or vice versa? So some patients are under the impression that maybe blood is a better way to do the genetic test. And the fact is that genetic testing certainly can be done through blood or saliva. The accuracy of the two is the same. It's just a matter of from where within your body we're obtaining your DNA. So either way is completely fine. We get asked quite often about these direct-to-consumer tests like 23andMe, and while they could be, fun and maybe useful for certain things, when it comes to a strong personal or family history of cancer, we don't rely on these tests to provide any accurate information. So some patients will say, well, I've already had 23andMe testing. I don't really need to do any more genetic testing. But certainly the 23andMe test is not nearly as comprehensive or as accurate as a clinical grade genetic test that's ordered through a qualified healthcare professional. So I do implore you, if you do have a personal or family history of cancer that's concerning for some underlying genetic predisposition, certainly don't rely on a negative 23andMe result to kind of ensure that there's nothing going on in the family. I tested negative in the past, therefore I don't need to do any more testing. And we hear that often from patients as well. Unfortunately, genetics is never really a closed book. The reality is that our tests are improving constantly over time, which is a good thing. But sometimes that drives patients crazy because they might think they're done when they test negative, but many patients come back to be retested maybe 5-10 years later because our tests are now better and looking more extensively at many newer genes. So if you've tested negative in the past, and if there is still a strong concern that the cancer may be hereditary in your family, we recommend that you discuss with your physician or your genetic counselor if there is any newer genetic testing that may be available at this time. I've already had cancer, therefore I don't need to do genetic testing. Kind of, what's the point? And just going back to that example of the red apple tree and the yellow apple, again, it is always ideal to test the person in the family who has had cancer. The information can benefit not only the family, but the patient as well, because we want to understand if they may have an increased risk to develop a new primary cancer. And that certainly may be useful in terms of their management moving forward.
Great. Thanks, Nicole. As always, fantastic. So before we go on to the questions for Dr. Nagar and Nicole Boxer, just want to kind of take a step back from these presentations because we really see that colorectal cancer, it's unique in its ability to be found early, even before it becomes cancer. So it's unique among cancers that we really need to think about it before it happens, before it causes symptoms. And as a process, it's amenable to be found early on when it's more easily treatable and curable. And, I think that this raises up the importance of screening. And there are a few questions from Dr. Nagar about screening, but probably the answer to all the screening questions is, I imagine, as long as we're all, as patients, engaged and involved in the screening process, whether, no matter what we do, as long as we're doing something, I think that's probably the best answer. And also for genetics and family history, just bringing up this concept of all of us being aware of our family history and reporting it to our physicians all the time. because there's one thing I've noticed is that as doctors, we take a family history in the beginning and we say, tell me about your family history, but we may not update that, as we go on. So as a patient, I think we should be constantly letting our doctors know, oh, I had an aunt or a cousin or someone else who's diagnosed with this, just to make sure that we don't become eligible for, or that we shouldn't be referred for genetic testing. So I think being aware of our family histories and reporting it to our doctors is really important. So as far as questions, I put in a couple questions. Deanna, are there any, should we go to the questions that I put in the chat, or are there any others first?
There are no other questions at this time, so we can certainly go with the questions that you have, Dr. Rath, but I would ask our guests, if you have any questions, please put them in the chat, or please feel free to take yourself off of mute.
Thanks, thank you. So Dr. Nygaard, and I'm sure you get this all the time. People say, gosh, is there a way I can do the screening? Can I avoid the colonoscopies by using the Cologuard or the FIT test or other? And I guess the second question sort of turns into that is let's say someone is having their colonoscopies every 5 or 10 years, whatever is recommended for them, what type of testing should they be having in between?
Okay, so for the first question, like you said, it's better to get any kind of screening test instead of getting none. But of all the tests, colonoscopy is the gold standard. Like we discussed, the stool test, they're good at detecting colon cancer, but they miss out on the polyps. And that's the chance that's the time we have a chance to get those polyps out to prevent the colon cancer. And as for your second question, how often they have to get it depends on a few factors. Now, what did we find on the colonoscopy? If we find polyps, and it depends upon the size of the polyp, the number of the polyps. So the larger the polyps, or if the number is greater than 3, or if it's a large polyp, we bring them back much earlier. For a person who has no family history and with no polyps, those are the people who we can screen at the next colonoscopy in 10 years.
So it sounds like it really should be customized. It should be a discussion between each patient and their gastroenterologist. Really, colonoscopy is the gold standard, but we have these other tests that can help support along the way and help give us more information along the way. But like, right, as long as people are thinking about it, not afraid of it, hopefully not too embarrassed, just get the test done.
Yes, that's right. So people who have no symptoms and no family history, those are the ones who actually can get this stool test. But if with a family history, or if they already have a colon polyp, then stool tests are not the options for them to get screening colonoscopies.
Right, and so just
screening test, I mean.
Right, screening is really for the average healthy individual who's not having any symptoms and doesn't have any important risk factors like strong family history or inflammatory bowel disease like Crohn's or ulcerative colitis or a hereditary syndrome like Nicole had mentioned, like Lynch. Screening is for the average Jane or Joe, no symptoms. That's what we're talking about here.
That's right.
Okay. And Nicole, not many questions because you're cute. Your myths and facts at the end always addresses them. Is there a time after which, 5 years or 10 years, if someone had testing at a major commercial lab and it's been 5 years or 10 years, is there a time frame after which you say maybe we should recheck, or does it always, I guess, depend upon what their risk factors were and what their family history was?
I would say, as just kind of a hard rule to start with, we started doing these panels around about 2014, 2015. So if you had your genetic testing prior to that time, certainly it's worth a conversation with your doctors about getting an updated test, because you probably were tested maybe for 1 or 2 of the main syndromes like Lynch syndrome or maybe something else, but you likely did not have one of these bigger panels. And that's something certainly that we consider kind of standard of care today. If you were tested more recently, I would say just when you check in with your doctor every 6 months, every year, especially if you have a very strong family history, it is worthwhile just asking them or maybe checking in with your genetic counselor if there's any updated tests that's available now. I'd say if you were tested within the last 1 to 2 years, you're probably okay, but that can change on any given day, really.
Sorry, I'm just listening to something.
Anna, any other questions? Does anyone have any other?
I see another question here on the chat, which is a very interesting question. If somebody had a colonoscopy or having colonoscopy every 5 to 10 years, should they get the stool test in between? So that's a very interesting one, because if you are having screening colonoscopy regularly and you follow the intervals, there is no real need to do the stool test in between, because the stool tests tend to have a higher rate of false positive tests. So a person will end up getting much more frequent colonoscopies than they actually need. So if they stick with a stool test, they just have to do it either annually or every 3 years, depending upon what they select. And if they have colonoscopies, they don't have to get a stool test in between.
Interesting. Okay. I see a question in the chat about diet, and I'm going to, if there are no other questions, I think the best is we'll have Cheryl Leslie discuss diet to address that question. Okay, maybe we'll move on to Cheryl right now. Thank you.
Hi, everyone. Thank you for joining us this morning. I'm going to be talking about ways that we can lower our risk of colorectal cancer through diet and also some lifestyle changes. So there are actually various lifestyle factors that have been linked to the risk of getting colorectal cancer. One is how heavy we are, our body weight, what we eat, how much alcohol we drink, our level of physical activity, and whether we smoke or not. The good news is that these are all things that we can modify. We can lower our risk by making changes, and this is all supported by research. The American Institute for Cancer Research is actually a great website that I'd encourage you all to go to, because they do a lot of research themselves. They look at a lot of research that others have done, and they conclude, and based on these studies, they will make conclusions as to what we can all do to lower our risk, not only of colorectal, but most of the cancers out there. So anyway, what they, based on the research for colorectal cancer, they estimate that about 47% of this type of cancer can be prevented by staying lean, eating healthy, and moving more, getting more activity. So first, let's go through the things that increase cancer risk, or this type of cancer risk. So a very strong factor is how heavy we are. In fact, there's strong evidence that shows that it's a convincing cause of colorectal cancer. The National Cancer Institute reports that people who are obese are 30% more likely to develop colorectal cancer than normal weight people. And the higher that the BMI level is, the stronger the risk. And we know that the risk really starts to go up once our BMI reaches above 27. So I don't know if you're all familiar with the term BMI. It stands for body mass index. It looks at how heavy we are relative to how tall we are. And it's categorized into normal weight, overweight, obese, severely obese, and morbidly obese. So it's very easy for you to figure out what your particular BMI is. If you go onto the internet and you search for BMI calculators, you just put in your height and your weight and it will tell you. So a normal range is up to 24.9. If you're between 25 and 29.9, you're considered overweight. Anything above 30 is obese, and the higher, the more severe the obese level. Next. Processed meats are another way, another thing that does increase our risk, and there is strong evidence that it is a convincing cause of colorectal cancer. So processed meats are meats that actually don't look the way that you would think they would look if you just got them from the butcher and cooked them. So they're smoked, they're cured, they're salted, there have been chemical preservatives added to them to give them that taste that we actually all love from these processed meats. So these are things like sausage, hot dogs, salami, ham, cured bacon, corned beef, smoked meats, beef jerky, any canned meats, and many lunch meats. Those are all considered to be processed. Now there is a 23% increased risk for colon cancer and 8% increased risk for rectal cancer for every additional 50 grams of these foods that we eat per day. So I know in the US, we're not used to dealing with grams, but this is equal to about 1.75 ounces, which is about the size of one hot dog. Now, the thing I want to point out to you is that, we all occasionally have these things, right? We may go to a barbecue and all there are really are hot dogs being served and you have one. You really don't have to worry about those very occasional times that we eat these meats. But if they are a regular part of your diet, you are increasing your risk of colorectal cancer. Okay, next. There's also strong evidence that having alcoholic drinks is a convincing cause of colorectal cancer. And our risk goes up if we have more than 30 grams per day of ethanol. Now, ethanol is the ingredient in an alcoholic beverage that increases our risk. So 30 grams is equivalent to about 2 drinks per day. I do want to point out, though, that for overall cancer risk, it is recommended that women not have more than 1 drink a day. So although under this criteria, you may think as a woman that 2 drinks per day would be okay, and it may be in the case of colorectal, but having that amount could increase your risk of other cancers. Okay, next. The thing you really have to pay attention to is the serving size. So 1 drink equals 12 ounces of regular beer, and regular beer are things that are like Miller or Budweiser. If you get into a craft beer, which have become very popular now, it's only 8 ounces for 1 drink. For wine, it's 5 ounces of wine, and for any hard liquors, it's 1.5 ounces, which is what you would get in a shot glass. It's really easy to have more than a serving of wine in 1 glass, right, depending upon the size of your glass. If you go out to a restaurant for the wine, they're pretty good about measuring out what would be 1 drink, but if you're pouring at home, you may be having, even up to 2 glasses of wine in 1 drink. So you have to pay attention to that. Okay, next. Red meat is also another food that will increase our risk of colorectal cancer. Be aware that it's not just beef that is red meat, it's also pork, lamb, and veal. And there's a 22% increased risk for colon cancer and 13% for rectal cancer for every 100 grams, every additional 100 grams, or that's about 3 ounces of red meat consumed per day. So the recommendation really is to restrict your intake to no more than 3 servings per week. Less, of course, would be even better. 3 servings equals about 12 to 18 ounces of cooked red meat weekly, and that would be 16 to 24 ounces raw. Okay, next. So those are the things that may increase our risk. Let's talk about what we can do to decrease our risk. Next. I talked about physical activity being one of those things that does decrease our risk. So there's strong evidence that this is true for colon cancer, that getting physical activity does protect us against colon, but studies have not shown any significant link for rectal cancer. However, we do know that physical activity affects our overall health and also risk of other cancers. So in 2009, there was a review of 52 studies, which is quite a few studies, and they found that those that were most physically active had a 24% decreased risk of colon cancer. And even after someone has colon cancer, having physical activity is associated with a reduced risk of dying from that disease. In fact, those that participated in physical activity had a 31% lower risk of death. So I encourage you, even if you may have a history, that you keep up any activity or initiate it if you're not doing it now. Next. The American Cancer Society recommends that to be at least moderately physically active, we should get 150 minutes of moderate intensity physical activity and 75 minutes of vigorous aerobic physical activity. So examples of a moderate intensity physical activity is, it could be things like doing housework. It could be weeding out in the garden. It could be, going up and down the stairs to do laundry. Some of the more active things that we may just do in our day-to-day life. But it is important to get the vigorous aerobic activity in, and that's where you would want to go out and maybe walk or swim, jog if you like to jog, climb a flight of stairs over and over again in a row, just to get your heart rate up, and that would account for being vigorous.
Cheryl, I'm going to interrupt. That's per day or something per week or per month?
Sorry, per week, per week. Yes, thank you for that clarification. But to really have, and if you are overweight by chance, to really have an impact in trying to, change your weight status, we really need to do 45 to 60 minutes of daily moderate intensity activity. So, try not to be sedentary, try not to sit around for hours at your desk if you work, or, watching TV. The recommendation now is every hour we should try to get up and move around at least for a few minutes to get our heart rate, going above a total rest area, a rest level. Okay, next. There's strong evidence that shows that intake of whole grains probably protects us against colorectal cancer. And what it seems to be is that if we eat at least 90 grams or 3 ounces of whole grains daily, we will reduce our risk by 17%. 3 ounces is really not a lot to have to do. So the food choices that would fall under the whole grains category are things like brown rice, buckwheat, bulgur, corn, sorghum, barley that has not been pearlized, having whole wheat products, quinoa, oatmeal, whole rye bread, or freekeh, which is another type of grain. So, if you just have, let's say, a bowl of oatmeal in the morning, you're probably almost hitting this. Okay, next. In line with eating whole grains, we know that there's strong evidence that if we eat foods that contain dietary fiber, it's probably protecting us against colorectal cancer. A review of 21 studies showed that we can decrease our risk for colon cancer by 9%, and for rectal cancer, 7% for every 10 grams of dietary fiber that we consume. An easy way to know how many grams we are eating is on a packaged food product. You can look at the nutrition facts label and it will tell you how many grams of fiber are in each serving. But when it comes to more natural whole foods, like let's say fruit, you can easily look that up on the internet these days. Just put in apple nutrition as an example, and it will, right away, it will pop up and show you all the nutrition facts about an apple and how much fiber is in it. So next. So the goal for men and women depends by age. So for men, if you are age 50 or younger, you should have 38 grams a day. If you're age 51 or over, it should be 30. And for women, it's 25 if you're in the younger age group, and 21 once you hit age 51. Next. So we also have seen from studies that consumption of dairy products probably protects against colorectal cancer. So the evidence is pretty consistent to show that there is a decreased risk of colorectal cancer when we have higher intake of total dairy foods, milk, and also dietary sources of calcium. The evidence for cheese consumption is actually less strong than it is for the other sources of calcium. Next. So you can see there are many foods that contain calcium. We always think, oh, we need to eat dairy, but for people who are dairy intolerant, that may not be an option. So here are all the other ways that you can get calcium in your diet. They won't have as much calcium as eating a dairy food, but you can still do it this way. So you can see there's plenty of choices. Next. Another option is taking calcium supplements, and there's strong evidence that shows that this probably protects us against colorectal cancer. I would say that if you have a lot of, if you're a big dairy eater and maybe you have a lot of the foods that do have calcium, you probably don't need supplements, but if you don't, this is another way to reduce your risk of colorectal cancer. So our risk decreases when we have 200 to 100 milligrams per day of calcium supplements. But there's really no specific dose recommendation based on the studies that are available right now. So it's something for you to discuss with your healthcare provider as to, maybe what is the right amount for you depending on how much you eat in your diet. Next. So in summary, there's many things that we can do to lower our risk of colorectal cancer. You can lose weight if you are overweight or obese. You can restrict your intake of cooked red meat to no more than 18 ounces per week. You can eat little, if any, processed meats. You can restrict your alcohol intake to 2 beverages a day. And if you're a woman, even one is even better. You can participate in at least 150 minutes of moderate intensity exercise weekly. Consume 5 to 6 servings of whole grains daily. Achieve your daily fiber goals based upon your age and sex. Include dairy or other food sources of calcium in your diet. And if your intake of calcium foods is insufficient, consider calcium supplements. Thank you.
Wow, thanks, Cheryl. We'll move on. We'll finish up with my talk, and then we'll open up for questions for Cheryl and for everyone. Okay, great. Well, thanks again. This will be the last presentation, and thanks to everyone for tuning in, staying in. What I wanted to do was just kind of pull in together some of what I thought were my favorite new topics and important topics regarding to colorectal cancer. I intentionally staying away from surgical techniques and chemotherapy. There have been a lot of advances, but I really wanted to focus on some bigger trends and threads in diagnosing and managing colorectal cancer that I thought were more interesting. So the first, like Dr. Nygaard mentioned, is a really big thing is that the age for screening, the typical risk, the average risk individual has been lowered from 50 to 45 over the past year. It's come down, and that's really a big deal. And I think that we are seeing more early age onset colorectal cancer, and we haven't figured out as a population, what are the risks, what's going on, but we are seeing it more in younger people. So it's not 50 anymore, it's 45. So whichever one of these icons or memes, sort of resonates with you, just remember at 45, that's when we have to go to our primary care doctor or gastroenterologist and begin that screening process with whatever modality. Next, please. And in treating with colorectal cancer, and by the way, for the purpose of this talk, we are kind of putting colorectal cancer together. The colon is the first and most part of the large bowel, and the rectum is a smaller part at the bottom. The treatment has been traditionally, sort of simple. Have a colonoscopy, get that diagnosed, have surgery, and then possibly need additional therapies, what we call adjuvant therapies, maybe chemotherapy, maybe radiation for rectal cancer. It sort of had been a linear process up until several years ago. Next, please. And now it's much more sort of matrix oriented and multimodality, which may be confusing, but it's also better. And it's certainly patient centered, and it can start anywhere from screening to genetic testing, colonoscopy or other procedures, and then we have the biology from the tissue sample from the colonoscopy. We have surgeons involved, radiologists, medical oncologists, possibly recommending systemic therapies, radiation, and of course diet and nutrition. Next, please. And it may seem a little bit confusing, but actually there's a pattern, and everything's all tied together. And at this point, once there's a diagnosis of colorectal cancer diagnosed, there is typically one person who's holding that purple crayon. Next, please. So there's one person, it's usually the medical oncologist, who's kind of keeping everything tied together, and it's really customized based on the individual, the patient, and their age, and whether it's colon or rectal, and even which parts of the colon or the rectum, and certainly nowadays the biology of the tumor, and are there these mutations or these immune markers. So it's become much more complicated than that prior linear pattern, but also more interesting and with better outcomes for the individual. Next, please. One new innovation that is already out there is identifying and measuring circulating tumor DNA in the blood. So we call it ctDNA for circulating tumor DNA. Basically, the concept is that most tumors, solid tumors, they may shed some abnormal DNA into the blood that's floating around. And the technology has evolved such that even drawing tubes of blood, the machines are so sensitive that they can pick up this abnormal genetic information, abnormal DNA from the tumors, even from the colon cancer, and identify it and measure it and compare it to previous samples. So this concept of measuring ctDNA is really got a foothold with colon cancer, and it's being used mostly for people who have been diagnosed with colon cancer and had surgery. It can be used as a blood test to see if people are at risk for relapse, or to monitor along the way longitudinally after surgery and even after chemotherapy. But that's just beginning with colorectal cancer. It's now they're looking at how can we look at it to diagnose and detect, and looking at other tumor types. So ctDNA has just gotten here, and I think we're going to be seeing a lot more of it. Next, please. Another topic that I'm really interested in is the microbiome. So the microbiome reflects all the different bacteria that we have in and around our body. And we have many different bacteria and different types and different families, depending upon whether it's in our skin or in our mouth or eyes or genitourinary or lungs. And what's interesting is that, you know, the bacterial cells are much smaller. If we remember from biology, those are prokaryotic cells as opposed to our eukaryote cells. They're much smaller. But in a human individual, for example, we may have about 30 trillion cells, but living on and with us could be more, 39 trillion microbial cells. And although we have about 25,000 genes, because there are more microbial cells and different types of bacterial microbial cells, there are even more genes numerically in those bacteria on and inside of us. And the microbiota, meaning if we add up all the bacteria, again, living with us, it actually represents about 1 to 3% of our body mass, which I think is kind of disgusting, but also really, really interesting. Next, please. And this is sort of a new area of research, seeing that this is a human superorganism. It's not just us, our fixed cells, our fixed DNA, but the microbiome, these different bacterial cells that are living in us and with us. And the interesting thing is that while our cells and our DNA are pretty fixed and don't change, the bacterial cells, these are changing all the time based upon medications or illnesses or diet or antibiotics or where we're going or the water we're drinking or our travel. So it's changing all the time. And these cells, they're not just static. They are making proteins and enzymes, and it's interacting with our body. So it can really perhaps put us at risk for diseases, be markers for how we might respond to treatment. So it reflects a whole new avenue of how we may take care of ourselves as a human superorganism. Next, please. And again, this sort of reflects that understanding the microbiome with respect to cancer might be able to predict who's at risk for certain type of cancers, or who might respond to certain treatments, or how to prevent. So this is really a really brand new field of study that's just being investigated right now. Next. It's up and coming. Actually, at White Plains Hospital, we have a study now for patients who are being treated with immunotherapies, and we're examining the microbiome by checking the blood and checking the stool for certain types of tumor types to describe and better understand our microbiome. But again, I think that we're just at the beginning of this interesting topic. Next, please. So I think this is my last slide, and this talks about a coordination of care through White Plains Hospital, and kind of going back to that the crazy purple crayon slide. With any tumor type, certainly with colorectal cancer, you don't need, or you can't just have one doctor or two doctors managing. You really need a team, and that team is going to involve medical oncologists and surgeons and gastroenterologists and radiation oncologists, and certainly the primary care doctor, but also behind the scenes, pathologists and radiologists, genetic counselors, dietitians. And we're really pleased to say that at White Plains Hospital, we spent years to transform our program to be in line and get certified through the Commission of Cancer, their nationally accredited program for rectal cancer. And this is a very specific program that make sure that there are certain metrics and quality procedures that are happening in this institution as we care for patients with rectal cancer. And we are only one of 45 programs in the country that are accredited through the NAPRC. Next, please, we're only one of 2 in the state of New York, the other being in Rochester. And next, please, we're the only one in the New York Metro Tri-State area that has accreditation through the rectal cancer program through the Commission on Cancer. So we're very happy with that. It's a testament to our commitment to our care for our patients with rectal cancer and colorectal cancer. Next, please. That's the end of my formal presentation and our formal presentations. I'd like to open it up for more questions at the end. And thank you guys all for your attention. And again, just recommend people be aware of their family histories and think about the recommendations for diet and activity and be involved with screening for colorectal cancer because it's really preventable and curable. So thank you so much. And why don't we open up for final questions?
We have a couple of questions in the chat, Dr.
Great. So let's see. I see someone asked, what's the target heart rate for aerobic exercise? Cheryl, do you have?
You know what, it depends upon your age. So what I would recommend for that, the easiest way to determine is if you go on to the internet and you search for target heart rate, you can put in, your age, your sex and whatever, and it will tell you what you should try to get up to. The American Cancer Society does not set as a criteria for lowering cancer risk to get to a certain target heart rate.
Right, I had seen years ago, and this is, they talked about 220 minus your age, multiplied by 80%. And
right.
I think that's been updated. I think you're right, probably for the purpose of this talk, speak with your doctor, but it's age related and it drops based upon your age and also has to do with your fitness. But it's somewhere in the zone roughly 220 minus your age times 80%, but probably speaking with your doctor.
The rule of thumb is that if you're getting some activity and let's say you're shooting for your vigorous activity level, you should be able to talk. Let's say you're doing it with someone, but it shouldn't be easy to talk. So, you should be a little bit out of breath, not tremendously that you're going to collapse, but you want to make sure that you're challenging your body and getting your heart rate up. And if you're doing that, you're not going to be able to have an easy conversation with someone.
Right. And I want to add that Dr. Nygaard, who had to leave and see patients, she mentioned that the last question she answered, that if someone's having colonoscopies every, say, 5 years or 10 years as recommended, and she'd said that you don't need to have any testing in between, she just wanted to clarify that was only if people are not having any symptoms, that it goes without saying that if someone's having any issues, any symptoms, changed bowel habits, pain, bleeding, anything that's abnormal, they need to have testing. They need to be evaluated. Cheryl, one of the things you've said in the past, which I like, and I try to apply and tell my patients, is eating from the rainbow, right? And then that's to try and get all those nutrients. Can you just speak to that a little bit?
Yes. So, if you look at the produce section in the grocery store, it's very, very colorful, right? You see, and we describe it as it's like a rainbow. So, we all tend to get stuck in the kinds of foods that we're used to eating all the time. But our goal should really be, particularly when we're picking out our produce, is that we eat produce, fruits and vegetables that are all different colors. Because, even though they all contain a base level of vitamins and minerals, but each color has slight variations in it. And also there's things in plants that are healthy to us that are called polyphenols, and each color has different polyphenols in it. So if you're only eating green foods or only eating, white foods, like let's say bananas and onions and some of the white fruits and vegetables, you are missing out on all the healthy compounds that are in all these different colors. So I encourage you to, be adventurous, try different fruits and vegetables that you maybe aren't normally eating, and they'll benefit your health potentially.
Yana? You're muted, Deanna.
Thanks, Dr. F. So I just wanted to go back to a question before Cheryl started presenting. And I don't know if it's really directed at Cheryl, but maybe all of you can answer this, or who's their best person. The WHO assigned processed meats as a level 1 carcinogen. I did not see diet and lifestyle as a risk factor. What are we doing to educate our community about lifestyle and diet to prevent colon cancer? Who wants to answer that?
I think it's always a challenge, of course, to get the word out there. I mean, maybe Dr. Raff can speak to this also, but, that's why we hold sessions like this. And, we hope that, here, we've had a group of people listening to this, and, as a healthcare facility, we try to get the word out, and, everyone we contact, we have come in contact with, we may be having these conversations, but you now all have knowledge yourself. And, if you can pass on what you've learned today to others, then the knowledge just grows and grows. So, it takes a village, as they say, and, we hold our events, and we do educate our patients and things and people who consult with us. But, it's really, all of us can play a role in helping this.
Yeah, and finding the messages, I think also finding the messages that sort of stick with you and speak to you. And it's hard to, whether it's colorectal cancer or anything, it's hard to make all the changes all at once. So for me, I think it's about reminding myself, surrounding myself, and picking on the things that speak to me, like eating from the rainbow, eating a rainbow of color fruits and vegetables, which Cheryl has said, that's something that sticks with me, and I tell my patients. And finding balance in your life with regular activity and exercise. So whatever the things that kind of work with you and stick with you, kind of lean into them and make them your own, and spread the word.
Great, thank you. So there was one more, Cheryl, this is directed to you. Do you know why the recommendations for daily fiber intake drop as we get older?
I'm sorry, can you repeat that?
Do you know why the recommendations for daily fiber intake drop as we get older?
Yes, it's really a function of, how our body systems just change as we age. And, our digestive system may slow down and all. So it's really not to overload our system with excessive fiber as we get older, because we may not be able to digest it quite as well. But I have to say, if let's say you're younger right now and you're eating a lot of fiber in your diet, and all of a sudden you hit age 51, like, I wouldn't say decrease what you're having. I think your body is used to digesting it. And unless you start to see any, discomfort after you eat the fiber, I would just keep going with it. But, a lot of these recommendations also, are based upon assuming that you're not eating a lot of fiber in your diet. And it's hard to go from 0 to 60 right away. So even if this is an area that you need to improve and you want to, start increasing the amount of fiber that you're eating, I would say start slowly. Maybe have a couple of extra, vegetables a day, and do that for, maybe up to a week, and then increase it more, and do that for a little while and increase it more. I often have people come and say, oh, I tried eating oatmeal all of a sudden, and it doesn't agree with me. I had a lot of gas, I was very uncomfortable. And so they stopped eating oatmeal. But, and particularly that happens a lot with people eating beans, chickpeas, kidney beans, all those beans. And it really isn't that they can't digest it. It's that they've now, haven't had it, and they overload their system, and their system has to almost adjust to digesting it again. So, I think it's not a black and white issue. If you're used to eating fiber, keep going, even after you hit these older ages, as long as you are comfortable. And if you're starting off, not a lot of fiber, then increase slowly.
Right. Okay.
Thank you. That's all I see. You see that someone's asking for a copy of the slides. So that is last question.
Right, well, Deanna, thank you so much. It's Deanna Nelson and all of our speakers and everyone here who stayed in and listened and asked questions. We really appreciate, and we'll sign off here. And oh, there'll be a survey going out, Deanna?
Yes, I will send out a survey.
That?
Thank you, everyone. Have a great weekend. Thank you for being with us today. Bye-bye.
Bye.
Bye.